Ευχαριστώ πάρα πολύ. Καλησπέρα σας. Κύριε Μαγκίνα, κυρία Άνθη, κύριε Αθανασόπουλε, κυρίες και κύριοι. Σας ευχαριστώ πάρα πολύ για την πρόσκληση να μιλήσω σήμερα. It is an honor for me to participate in the 22nd Symposium on Echocardiology and Advanced Cardiac Care organized by the Onassis Cardiac Surgery Center. I'm sorry I cannot be there in person, but I look forward to meeting in person in the near future. My talk today is on the evaluation of the right heart in pulmonary hypertension, considering both resting and dynamic performance. I have no conflicts to disclose. So I'd like to first start with a clinical case. This is a 68-year-old woman who presented to our hospital a few weeks ago with progressively worsening dyspnea over the previous 6 months. Her past medical history is significant for diabetes and Raynaud's phenomenon. On physical exam, she had sclerodactyly and telangiectasias were also present. And an echocardiogram was performed. And here's a few of the images from the echocardiogram. What is apparent in this parasternal short axis view is that there is septal flattening in systole, suggestive of a right ventricular pressure overload consistent with pulmonary hypertension. The patient also had tricuspid regurgitation, and by measuring the velocity of the tricuspid regurgitation jet, we are able to calculate the right ventricular systolic pressure from the gradient of 70 here plus the right atrial pressure, so the right ventricular systolic pressure was over 80 millimeters of mercury. In addition, when looking at an apical 4-chamber view, what is apparent is that there's right atrial enlargement, and there's also right ventricular enlargement and right ventricular hypertrophy. There also appears to be decreased right ventricular systolic function, and this is something that we're very much interested in. What are the ways that we can better quantify the degree of right ventricular systolic dysfunction? Well, there are a number of standard measures of right ventricular systolic function that we typically use. These include TAPSE, which is the tricuspid annular plane systolic excursion. We can also measure the right ventricular S prime by tissue Doppler of the lateral tricuspid annulus. And in addition, we can measure the right ventricular fractional area change. So this is how we measure TAPSE in this patient that I just presented. We perform M-mode Doppler through the, we perform M-mode through the tricuspid annulus, and this allows us to measure the motion of the annulus at the end of diastole and then at the end of systole, and measure the distance that it traverses, which in this case was 13 millimeters, with abnormal being less than 17 millimeters. Similarly, we can also place a pulse wave sample volume at the tricuspid annulus to measure tissue Doppler velocities, and we can measure the velocity in systole of the annulus towards the transducer, which is shown here with this wave here. And this is the right ventricular S prime, which we measured at 8.2 centimeters per second, with abnormal being less than 9.5 centimeters per second. Now, these measurements of TAPSE and S prime have several strengths. They are easily obtainable and they are fairly reproducible. They are also less dependent on image quality. However, they also have limitations. They are angle dependent, and the measurements are relative to the transducer and not necessarily anatomic, especially if the heart is not well aligned with the direction of the ultrasound beam. In addition, they are impacted by tethering and cardiac motion. So we can get around some of those limitations by doing measurements of the 2D image and measuring the fractional area change of the right ventricle. This can be performed by measuring the area in diastole and also again in systole at the end of systole. And this can provide us the fractional area change, which in our patient was 29%, with abnormal being considered less than 35%. So this was also reduced. Now, these standard measures are helpful in monitoring response to therapy, but they do have some limitations in predicting mortality in pulmonary arterial hypertension. This is a meta-analysis that was published several years ago, looking at the relationship of TAPSE to mortality and right ventricular fractional area change to mortality. And what you can see here is when you look at the summary of all the studies, the hazard ratio crosses 1 for both TAPSE and again for right ventricular fractional area change. So these measurements do have limitations when it comes to predicting survival in pulmonary arterial hypertension. And there is a need for more advanced measures that are better than what we currently have. So there are advanced techniques to assess right ventricular function. These include right ventricular strain, as well as the 3D assessment of the right ventricular ejection fraction. So just as we can perform strain imaging using speckle tracking of the left ventricle, it can also be performed with the right ventricle. And in order to better standardize how this is performed, a task force was formed by the EACVI and the American Society of Echo, together with our industry partners, to standardize deformation imaging of not only the left atrium, but the right ventricle and the right atrium as well. And this task force published a consensus document in 2018, which included recommendations. And for the right ventricle, the recommendations for measuring right ventricular strain included using a right ventricular focused apical 4-chamber view, as shown in this schematic. And the recommendation was also that RV free wall longitudinal strain should be reported, which is determined by taking the basal, mid, and apical free wall strains and averaging the 3 together. And here's an example from our echo laboratory of a patient with normal right ventricular strain. We have put the sample volume tracing the entire right ventricular free wall as well as the septum. And from this, we can measure the right ventricular free wall basal strain, mid strain, and apical strain. And the 3 curves are shown here. And by averaging the 3 together, we get a right ventricular free wall strain of negative 35.6%, which is normal. Abnormal is typically considered as a magnitude of less than 18 to 19%, depending on what study you look at. Now you can see how vigorously this right ventricle, which is normal, how well it's contracting. In our patient that I presented, it's apparent that when we do the right ventricular strain analysis, that the right ventricular strain is significantly decreased. And in this case, the right ventricular strain was negative 14.5%. So how can right ventricular strain help us in pulmonary hypertension? Well, this is a study by Fine and colleagues from the Mayo Clinic, where they looked at 575 patients prospectively who they evaluated for known or suspected pulmonary hypertension. And what they found was that patients with severely reduced right ventricular strain, shown in red, had the highest mortality. Patients with moderate reduction in right ventricular strain had an intermediate mortality at 18 months, and those with only mild reduction or normal right ventricular strain had the lowest mortality. So another advanced technique that we can use to assess the right ventricle is that of using 3-dimensional echo to determine the right ventricular ejection fraction. Now, the right ventricle does not lend itself to 2D assessment of ejection fraction because of its irregular shape, which makes a lot of the assumptions that can be applied to the left ventricle invalid when trying to apply them to the right ventricle. However, if you do 3-dimensional echo, you can get around those limitations and you can get an accurate ejection fraction. This is an example of a patient with a normal ejection fraction of 64%. Abnormal of the right ventricle is considered as less than 45%. So in this study by Vitarelli and colleagues, they looked at 73 patients with chronic pulmonary hypertension who during follow-up had a 2-year mortality of 18%. And they looked at their echoes in whom they looked at what the echo predictors were of outcome. And they found that the univariate analysis included significant predictors such as the standard measures of S prime and TAPSE. And they also found that right ventricular free wall strain, which they obtained using 3D, was a univariate predictor, as well as 3-dimensional determined right ventricular ejection fraction. When they did multivariate analysis, the only significant predictors of outcome were the free wall strain and the 3D RV ejection fraction. So it appears that these new advanced techniques have incremental value in predicting outcome in patients with pulmonary hypertension. Now, it's not just the right ventricle that can be useful in predicting outcome, but the right atrium can also be helpful when we assess them for echo markers of prognosis. The right atrial echo markers that can be helpful in pulmonary hypertension include right atrial size, determined by either two-dimensional or three-dimensional echo. And in addition, in this study published by Julia Grapsa and Petros Nihoyanopoulos several years ago, they found that right atrial sphericity index by three-dimensional echo was also associated with outcome in patients with pulmonary hypertension. So it's not just the size, but it's also the shape of the right atrium that can be associated with outcome. And I will also like to talk about right atrial strain. So just as we can do strain imaging of the left atrium, we can also perform it of the right atrium. Here's an example of performing speckle tracking of the right atrial wall, which allows us to generate a right atrial strain curve as shown here on the right. Now, the task force also in the consensus document made recommendations on measurement of right atrial strain and recommended that the zero strain reference should be placed at the end of diastole at the QRS complex, and this then allows us to measure the peak of the right atrial strain curve, which corresponds to the right atrial reservoir strain. And this is the strain parameter that has been shown to have utility in predicting outcome in pulmonary hypertension. So this is a study that we performed at the University of Michigan, looking at 37 patients with group 1 pulmonary arterial hypertension. The patients had right atrial reservoir strain measured and were also evaluated for a composite endpoint of prostacyclin initiation, lung transplantation, or death. And what we found was that in patients who ended up meeting the primary endpoint, their prior echo had a significantly reduced right atrial strain compared to those patients who did not meet the primary endpoint or compared to normal controls. So it's apparent that right atrial strain is also associated with outcome in patients with pulmonary hypertension. Now, all the measures that I have been discussing up to this point have been resting measures of right ventricular and right atrial function. But dynamic assessment of right ventricular function can also be performed. Stress echo provides the opportunity to unmask early RV dysfunction. Stress can be performed using recumbent bicycle exercise, treadmill exercise, or dobutamine. And it allows us to compare rest and exercise parameters of RV systolic function, which allows us to measure RV contractile reserve. This is a study by Chia and colleagues in Australia, where they looked at a group of normal controls as well as a group of patients with systemic sclerosis without known pulmonary hypertension, and then patients with pulmonary arterial hypertension. And they did resting and exercise echo, and they measured the change in each of these parameters with exercise. And you can see in control patients, the TAPC significantly increases, S prime increases, fractional area change increases, and RV strain and systolic strain rate also increase. Now, just focusing on the pulmonary arterial hypertension group, they had a different response to exercise compared to the controls. The TAPC did not significantly change. S prime increased only modestly, as did fractional area change. The RV strain actually went down, and the systolic strain rate increased, but only modestly compared to controls. These were all significantly different compared to controls. Then when they looked at the systemic sclerosis patients who did not have pulmonary hypertension, they also found that there were differences. So the amount of increase in TAPC and S prime were significantly less in systemic sclerosis compared to control patients. The fractional area change and RV strain were also less, but did not meet statistical significance. But the systolic strain rate also was significantly lower in systemic sclerosis patients compared to how much it increased in control patients. So this group really illustrated that you can unmask RV dysfunction by doing exercise in these patients with systemic sclerosis. So those parameters can be done. That study showed that the parameters can be done. But one question arises is, what's the feasibility of doing these parameters with exercise in a widespread population? And so this is a study that was just published this year by the Right Heart International Network, looking at nearly 1,000 patients or 1,000 subjects at 7 centers, and looking at the feasibility of rest and stress parameters of RV function. And when they looked at TAPSE, the feasibility was very high, 98% at rest, and equally high with stress, at 96%. When they looked at S prime at rest, it was very feasible. It was quite feasible with stress, slightly less than at rest, but still quite high, close to 90%. When they looked at the feasibility of right ventricular fractional area change, although it was very feasible at rest, with stress it was only feasible in about 2/3 of the patients. The other question arises is that even if it's feasible, how reproducible is it? So the same Right Heart International Network also looked at the intra-observer variability of these measures of TAPSE, RVS prime, and RV fractional area change. And we also include here the EF for comparison. And I'm going to focus on the intra-class correlation coefficient as the measure of reproducibility, with the blue shown at rest and the green shown with exercise. And what you can see here is the ICC is quite high for TAPSE at rest, 0.97, and remains quite high at 0.95 with stress. Similarly, the RVS prime is also quite high at rest and with stress. The fractional area change is lower. There's more variability for this parameter. It's 0.82 at rest and 0.80 with stress. So similar between rest and stress, but equally low. And for comparison, the EF reproducibility was quite high at 0.97 at rest and 0.96 with stress. And lastly, I would also like to highlight a nice study that was just published by the group in Athens here, looking at pharmacologic stress to assess pulmonary hypertension and RV function. And they performed albumin stress in patients with systemic sclerosis. These patients had a resting echo that was non-diagnostic for PAH and had normal RV indices. And the patients underwent low-dose albumin echo at the time of a right heart cath. All the patients were characterized as either positive or negative for PAH on the right heart cath. And among other things, one thing they found when they focused on the RV function was that the change in TAPSE was significantly less. There was a much smaller increase in TAPSE in patients with pulmonary arterial hypertension than those that did not have pulmonary arterial hypertension. Likewise, the increase in RVS prime was also significantly less in patients with pulmonary arterial hypertension compared to those who did not have pulmonary arterial hypertension. So they illustrate that the dynamic assessment of RV function and of pulmonary hypertension can take place not just with exercise, but also with dobutamine as well. So in conclusion, there are a number of standard measures of RV systolic function that can be used in pulmonary hypertension. These include TAPSE, RVS prime, and RV fractional area change. These are all easily obtainable, but they do have limitations. Advanced techniques of RV function assessment include right ventricular strain and 3D RVEF, and these have a significant potential to really improve our understanding and our prognostication of outcome in patients with pulmonary hypertension. In addition, right atrial assessment can also be performed, including assessing RA size and shape and determining RA strain, which can also help in determining outcome in pulmonary hypertension. And also dynamic assessment of the right ventricular function can be performed by using stress echo to evaluate change in RV function parameters. Lastly, there's ongoing investigation using advanced techniques with exercise, especially right ventricular strain, which is something that has been of interest at our center as well. Thank you for your attention. And at this point, I'd be happy to answer any questions.
Thank you very much, Professor Kolias, for this superb presentation. You gave us a lot of very useful information on the resting and stress indices, evaluating the RV performance and behavior. Obviously, as you said, the dynamic evaluation for RV, it's very good to unmask some kind of subclinical dysfunction of the RV and not so much to follow or get information on the established RV dysfunction. The question I have is the following. Now we live in the era of upfront combination therapy of pulmonary hypertension. And I wanted to ask, in a similar way that we don't get immediate results when we start epoprostenol, in the days within the hospital, in the small, let's say, dosage of epoprostenol, but we expect a much better clinical improvement in the weeks and months to come. If we use dynamic evaluation of the RV behavior with dobutamine, we may not see some changes acutely from the upfront triple therapy, let's say, which means that we may be disappointed acutely, but an upfront triple therapy might give a good clinical response. Is it good? I mean, I always try to understand why we don't have so many stress studies with dobutamine, let's say, or with bicycle. I think it deserves more research, this area. So the acute response to dobutamine should not disappoint us from starting or selecting combination therapy. And it may give us information very, very useful.
Yeah, I agree. I think that's a very good point. I don't know that there has been much work that has really looked for the response and looking at exactly what you're pointing out, what the response will be later on. And I think it does deserve further investigation. I'd be interested if, anyone else has any experience with that too.
Dr. Athanasopoulos has a question.
I have to thank you, Professor Kolias, dear Theo. You gave us a very, very elegant lecture on this very difficult topic of how to handle the RV function, the right ventricular cavities function. You have done an excellent work about right atrial function. Did you find any relationship between these data concerning right atrial function and right ventricular performances, specifically the right ventricular strength performances? There are some concerns by Jan Subevoit, you're aware of that, that actually the atria are the mirror of the ventricular strain performance. So is it the case on the right side, or we have an additional input from right atrium itself in the interrogation of the function of the cavities, of the right cavities?
Thank you for your excellent question. And I agree with you completely. I don't know that in that specific study, we didn't do a comparison for the right ventricular strain. But I know, and actually I think just this week, Jan Subevoit's group published the data that you were just talking about too. I think that more work actually deserves to be done in that area to try and sort it out. When we look at the left side, there was similar thoughts that, the primary determinant of left atrial strain was left ventricular strain. And although it's probably a major determinant, it turned out not to be the only one. And so I think that there's probably more work that deserves to be done on the right side looking at that as well. One of the things that also I think may play a role is when we do atrial strain, there tends to be less motion of the myocardium of those walls. So they may also allow less noise in some of the strain signal than we sometimes can see in the ventricles too. And whether it's just another way of looking at things that is less noisy, I think also is a factor that needs to be considered as well. But I think what you pointed out is an excellent point, and whether it's really looking at the same thing or whether there's additional parameters that we're seeing with left atrial strain that we're not reflecting in left ventricular, I'm saying right atrial strain that we're not reflecting in right ventricular strain, I think deserves further study. The one other thing I think that I would say is, the right atrial strain may be reflecting more the diastolic function of the right ventricle. So maybe giving us some information in addition than what we're just seeing with the contractile function of the right ventricle, similar to what left atrial strain is doing with left ventricular strain.
Yes, and recently I have communication with Jarek Karczak, who participates in the study, about this issue of dynamic evaluation of the right cavities, especially on the topic that Dr. Manginas mentioned before in the eligibility for upfront therapy. And I think that this is a very interesting topic to be studied clinically, because at the moment we have been behind, we have lost pace in using properly the right cavities dynamics in clinical handling of therapies in pulmonary hypertension.
I agree. I think that's a great idea. I think it really does deserve more attention as we do investigations moving forward.
Thank you very much, Professor Kolias. And that was a great session. And Dr. Anthi, if you don't disagree, I think it's time to proceed with the next special lecture by Professor